Thank you for coming today. It's really cool just to see what's happening. This is our fourth event, and let's see if I can switch this here. So we did our first event in Stevens Point, we had over 100 people, so that was kind of surprising to us, but I think what it's showing is that there's a need and a recognition out there. You know, if you strike up conversations with the public in a bank or wherever, I had coffee with a broker a few weeks ago, and the waitress, so just 2 coffees, you know, so the waitress came over and she said, that'll be $427, you know, instead of like $427 or something. And I was like, sounds like healthcare. And then she goes, oh yeah, I got a story. And then she starts going. So it seems like everyone you just randomly talked with about healthcare, they have a bad story. It's like, so I think there's a need that's ever developing, and kind of the attendance to these shows that. So hopefully we have some good information for you today. My talk today is something I've done similar. I've tried to, keep it fresh, but is honestly not one of my favorite talks, if you will. It's because what it does is it shines some light on some of the realities of why we're here and why we need to be here and why we need to move, right? The core word of the word movement is move, and that's for employers, the payers of healthcare. So often I leave these kind of talks feeling kind of down, like, right, because it's kind of critical, it's a little bit critical. It's not meant to be. I just want to kind of say that. I think it's really coming more from a platform of justice. I don't wake up, people have called me all sorts of things, and a disruptor, and like, oh no, man, I meant that as a compliment. I'm like, it sounds like I'm a troublemaker, right? Like, I don't wake up and say, what can I disrupt today? I wake up and say, what can I make right today? So this is a grassroots movement, not trying to cause trouble, trying to restore healthcare to what it should be. So we'll kind of jump in here. So my story started in a VP of HR role on the healthcare side. I'd kind of known about healthcare, but we really dug in. What started as kind of a somewhat, I don't think naive's the right word, but certainly I didn't know very close to what I know today, 7 years later. And we learned a lot along the way. It started as a drive to preserve our plan, keep costs down, and so forth. And then it just kind of built and turned into this journey and a story and all sorts of things. So 7 years ago, I'd been through the enrollments, HR leadership for 23 years, but I didn't know all the strategies and the things that we can actually do that I know today. So wherever you are today, if you're like, I don't understand this language, they're using all these acronyms, I would just encourage you and say, it's okay. Just start reading. I can recommend books, right? I mean, there's videos. We're starting to put out education videos, and just start learning and start your journey. And so it's not something that you have to be there today. It's just kind of an ongoing thing. But we did some cool stuff. We started with on-site clinics. We did on-site MRI, X-ray, on-site physical therapy. We did, and we started then finding bundle prices, right? Prices, vendors or providers that tell you the price, imagine that's in healthcare, that tell you the price, that bundle the price, and have often maybe a 25% of the price of a hospital system. So a lot of it, right, I think we're past reform. In my opinion, a lot of this is kind of a system avoidance, right? So if we come to the conclusion, if we look at the hospital system and say, they don't tell us the price, even if we ask, and I know there are some new laws that might change that a little bit, but that's at least their attitude. They don't tell us the price, they don't bundle the price, they send you pieces of bills, and they keep coming. They'll sue you quickly. The quality of care is low. If you look at the primary care, it's evolved into a referral machine, etc. Okay? So if we look at the system and say we can't win with them, I don't think there's a way to win with them. So how can we then create kind of our own system? We start with DPC, independent clinics, and we go from there. So that was our story at Merrill Steel. So I think I think we all know probably about rising healthcare costs, so I'll kind of breeze through this. But one of this graph on the right, one of the things that's important to understand is that I would say, like, I have family members that work in these hospital systems still, and they're frustrated much of the time. But just to point out that it's not necessarily the doctors, the nurses, the other staff. What we're really talking about is the administrator level manipulating things for money. So just to point that out, because we probably all have family members, it's not like we're criticizing everyone in the hospital system. We're really just trying to expose truth of how things got where they are, and it's become more of a money game than it has a healthcare game. So here's the fun stuff, right? So sometimes, they say sunlight's the best disinfectant. So I have many friends that are brokers. Hopefully they'll remain friends with me after some of these talks. But what we're really trying to do is separate the wheat from the chaff and just say, which side are you on? Because there's been things happening for so long. If you look at the last 20 years of healthcare, the costs are absolutely out of control. And so then we start to look at why, right? I was trained early at Toyota Motor Manufacturing. Why? Keep asking why to get your root cause until you can't ask why anymore. When you get that root cause, if you eliminate the root cause, the problem goes away forever. Some of that's pretty complicated in healthcare. But it's important. One of, if not the first step, or one of the most important, unless you're going to be your own broker, which can happen, but it's rare. You have to have someone internally that's really knowledgeable and so forth, and it's time. But in most cases, you partner with a broker, sometimes called advisor. Names don't really mean anything. It's more about their actions, right? But the broker role. So it's really important to partner with someone who is going to help you. And I sent out a note yesterday. If you're on the list, if you're not, there's the sign-up sheet out there. I can add you to the best practice list, the healthcare best practice group. But I've kind of broken down maybe one way to look at brokers is there's kind of three types, if you will. The wet blankets we see a lot, and maybe it's fear, maybe it's they're getting commissions. I can't really say why. Maybe it's different for each one, but you talk about a good idea, even a proven idea. It's like, hey, we did this and it really worked. The employer goes back to their broker and they say that won't work. And the conversation's over, and then they go work on something else, staffing or something, right? We've got to stop those conversations. I always say to people a lot of times, don't tell me all the reasons why we can't do something. Tell me why we can. And it doesn't mean we can. I get it. If there's enough things in your way, sometimes you have to face reality. But be careful, I'll say in advance, because especially a best practice that's proven over and over and over again, don't tell me it can't be done, because it can. Right? And each case is different. Look at your situation, look at your area, look at all the factors. But those wet blanket brokers are very dangerous. What we've seen, by the way, that one of the reasons I talk about these things, because we have to, but I've seen brokers, right, they're like, yeah, I was trained this way, I was brought up this way, and you know what, I don't like it, and I want to do things differently. Good for you, right? So it's not like trying to label people or permanently peg them. It's a lot of times they'll change. They'll be like, I get it, let's do some good things. This is affecting our communities, our families, and ultimately our future of healthcare for our nation. The weather vane, I heard this from a colleague over in western Wisconsin, so I like this, right? The weather vane broker that kind of shifts with the wind. It's like, hey, we want to do this. Yeah, we're cutting edge. We're doing all these things, or whatever. It's like they just mirror, and but they never actually achieve anything. So it's really just a really good sales talk. And they're not, right? It's just, and I get it, it's really tough, but it's not this genuine, like, let's go do something. Let's make this graph look better. What are the outcomes, right? Let's make these outcomes look better. Just that, right? I have an impression that most of the time when you try, you'll achieve something. So not trying is the error. And then kind of what I've labeled as courageous and competent, call them whatever you want, right? Brokers, right? The ones with courage, not foolish courage, like not jump in and then ask how deep the water is. Know what you're doing, but just have some courage, do the research, learn about it, learn about best practices that have been proven now over and over. When we started in 2016, there was a lot of exploration. Some of these things weren't proven. There were others, like serograph that started way back in like '03 in Wisconsin. But a lot of these things now have been proven to work. So it's not some kind of high risk or experiment. And look at your trends, right? Often we don't even do this. Are you getting better? There's simple questions, right? Are you getting better or getting worse? Or don't you have a graph that even tells you that? If you don't, get one. All right, cost-wise, year to year, by the way, not month to month. Month to month is confusing. We don't care if summers are higher or winters are higher. You can measure it if you want, but really year to year, are we getting better? What are the things that are important? And are we getting better or getting worse? That'll tell you a lot, and that'll motivate you to do something. So one of the best measures too, if you're looking for kind of a standard measure, per employee per year, if you're not familiar with this language, but how much cost per employee per year? That's kind of apples to apples type measurement, right? And then we can say, well, you're high, you're good, you're low, whatever it is. And then there's other factors like how rich is your plan, if you will, right? All those factors aren't necessarily indicated by that measure alone, but that's a good place to start. And lastly, on the brokers, just make sure, right? So we see in the insurance industry, make sure that your partners that are supposed to be helping you get better aren't making more money as your plan falls apart. That may not be their fault, so like don't, but just bring it up and then say, can we change this, please? Because if you're trying to help me lower cost on my health plan and you're making more money when my premiums go up, we have a conflict here that's putting you in a bad spot. Let's change that, right? That's happened for 20 years. Insurance companies. So one of the things to realize with insurance companies is, right, they pretty much with good actuaries, I mean, never say never, but they basically aren't. The formula is that they'll never lose. So if prices go up from hospital systems, they're just going to raise their prices, right? So they're not going to get, there's pretty rare cases where they're going to get burned unless they mess something up or there's some extreme case. So the commissions, I've talked about kind of be careful of the conflicts. When I worked for Fortune 500 companies, I couldn't even accept like pens or baseball caps. And that was a conflict of interest according to a very thick and strict standards of business conduct book. If you applied some of those things to what happened in healthcare today, they're called different things. They would be policy violations. So, just kind of an interesting perspective. I like to make a statement to say that if you're fully insured, there's no way to win long term. And maybe there's some rare exception out there, but you might get a 0 this year, but over time, you're gonna get a 30 next year, right? You're gonna get burned. Now, that didn't used to be this way. 20 years ago, it didn't used to be this way. You could be fully insured and you could be okay. And the last 20 plus years or more, this has changed where I don't think it's a winning game anymore. I don't think it's a sustainable game. When we talk about, free market kind of stuff, if you have, think about it, right? If you go into I was talking with a person earlier, going to a tire shop, you're buying tires, or a restaurant, or applied or whatever, free market. If I go into a restaurant and the food's cold and I get bad service, what happens, right? I might say something, but I don't go back, or I expect a change. In healthcare, you have, if you're fully, you have insurance in the middle, and the hospital systems, it's like, well, I got 8 bills, I don't understand them, they're up-coded, this one I didn't even receive, and I owe $2,000, and I call to complain, and they act like I'm out of line. I was in the hospital once, and I was charged $400 for a physical therapy. It was a 5-minute discussion, which I said I already have a physical therapist. And I called, and I was the one out of line, right? So, there's no power there because I can't say I won't go back. Well, they got me, because insurance is paying them, not me. And the whole thing is, it's a block free market. And then also not sharing data. If you're in a case where you're fully insured, like we have Madison, for instance, is mostly fully insured, different areas, but where companies really should be self-insured, they're large enough and have the numbers and so forth, the insurance then won't share any of the data. So you kind of go into that transfer kind of line. There's ways, there's surveys and things we can do, but if they make that transition really difficult. And so the question might be, is in all this message, who do you trust, right? Who do you trust? I ask you a fair question. I'm paying you lots of money and you can't give me any information. And you won't. Maybe I don't trust you anymore. Who should I trust? I trust people that are transparency is the currency of trust. Right? And then lastly, of the fun stuff, so hospital systems, just some sunlight, if you will. The MLR, by the way, the medical loss ratio, which was made more formal by ACA, the ACA law, Obamacare, ACA, same thing. I find it interesting, and not to say this is every case, but if those two are sitting at the negotiation table, the insurance company's sitting there, let's say they get to max at 20% of the profits, and the only way that CEO can go back to the board and say, I increased revenue, is if premiums go up. So the hospital system wants premiums or wants claims to go up. So you have two people sitting at the negotiation table that can leave there smiling if claims go up. And the payer, the employer, isn't even there. I just found that kind of fascinating. Like, wait a minute, time out. So I think there's things like that that have tainted where we are. I don't know any other situation like that where the payer's not present and the costs keep going up at alarming rates. So restrict, right? If you call a hospital, restrict price transparency in Wisconsin, where we have the wonderful honor of being the fourth worst state according to the most recent RAND study. We'll have Wellbridge here later today. They're the sixth worst. So it's more call for action for Wisconsin employers and all those involved in improving healthcare. We have more opportunity. I would say problems are just opportunities in disguise, but we have lots of opportunities here in Wisconsin for healthcare. And this is fun for me, and I know that's kind of weird, but it's like, hey, let's go do some cool stuff, right? But when you're fourth worst in the nation, hey, if you were like 42nd, I'd be like, yeah, let's work on something else, right? Okay. So Jay Kempton, in one of his quotes, no effort to manage cost, he says, the seller's inefficiency has become the buyer's problem, right? In your business, if you have too much cost and you can't get your prices down, the buyer doesn't look at you and say, that's okay, I understand, you're inefficient. I said, no, get your cost down or we're gonna shop over here. In healthcare, it's like, no, it's your problem. Rush primary care, so lots of stuff, way more to cover here than time allowed, but that's one of the reasons DPC has taken over so much and popping up and becoming a thing is because we interrupt and we start to interrupt with our own funnel. That's how the systems collect their patients, is a loss leader really. But 15 minutes, took you 3 to 6 weeks to get an appointment. You have 15 minutes, that's shrunk to 7 or 8 by the time you have vital scale and blood pressure. And the doctors have told me, several, say when I walk in that room, I got like 2 more people waiting already. I'm rushed. All I have time to do is halfway interrupt and refer. So say as many as half of the referrals from system primary care are unnecessary. They could have been handled if the person had time. And then they're also incentivized to refer. They're called RVUs. And so there's a lot of cost. There's time away from work. There's a lot of cost there. And is that good primary care? Primary care is like maybe is 80% of your health care. So, good place to start, right? So, many lawsuits, lots of lobbying. So, okay. So that's just some of the realities of where we are. Not necessarily fun to talk about, but one of the concepts of leading change, and this is something I studied in school, and I was really, before I got into healthcare, I was all about leadership development, changing cultures, and I was, doing that. But here's a little nugget for you, because if you're gonna lead change, one of the tricks, if you will, or techniques, is that before someone is willing to come with you on a journey, like if you're in a company and they say, and you bring up change and everyone goes, oh, not again, right? Why is that? Well, part of it is because change is hard, and we like to do things we know and not new things. But one of the most important techniques of that is that before someone will come with you on a journey, they have to be willing to let go of where they are. So that's why I let off like this, and that's why I talk about this. I don't really, right? But if you or the people you lead aren't willing to let go and say, we can't stay here. We can't stay here anymore, it's too bad. Then you can begin to look for new solutions. Often we have great meetings like this or conversations. You may leave here all pumped up and go back to your team. We need to go here, here, here. And they're like, but you haven't told me I need to let go. So even if you start something, a change, if they haven't let go, it's going to be a rough change because they're still hanging on to the old, right? So you've got to get them to let go. And we have to let go as well. So kind of a nugget for you. This is just a picture representation that I put together so when you're on a fully funded side, right, it's like you just kind of sign here. It's real easy for brokers and employers. There's even commissions and all sorts of things attached. But it's all, the network's there, everything's kind of done, even though the outcomes have become unsustainable. So you can't really stay there, you can't really go there. But when you go to the fully funded side, right, that stuff, and that's what John and I are doing in our business, is building this full strategy, etc., full partners. But if you want to DIY, when I was at Merrill Steel, right, and many of the success stories, we had to DIY this. So there's your alternative, DIY or find someone who's put it together. But we had to build this case by case. It's like, oh, PT, we can interrupt. Our PT sitting here, Boyd Smith, Dr. Boyd Smith. We can interrupt with PT. We can prevent maybe half the surgeries. We can have someone to hold their hand when they do need surgery. We can get bundled surgeries at 25% of the cost. That's a good interruption. That's a good intervention. That's just one of like 30 pieces. So I had to find one, set it up, how's this fit into the benefit plan, all these things. You have to build, right? So it's a complicated thing. It's not just sign here to be successful. That's why there aren't maybe a lot of stories in Wisconsin. We're learning them more and more. There's 2 or 3 over in Western Wisconsin that I wasn't aware of that are really doing some cool stuff. What's interesting is a lot of them have the same approach, kind of a system avoidance kind of approach. So this picture tells a lot. I always joke way back in like 17 or something, I had wrote out like this 5-page strategy, and I was really excited. And I sent it to like 75 people. This is it. And I always joke about guess how many people responded to me, like even my own team and everything, like 0. I was like excited by myself. All right, so it's like, so I don't think anybody read it. It's like, we're all busy, 5 pages, seriously, Matt, right? So I talked to someone and we said, let's draw a picture. I'm scratching on my whiteboard. Here's what this 5 pages looks like in a picture, right? So this narrow network, which is feel like I kind of fell for this, right? But if your hospital system says, oh, this is top-down pricing opposed to clear bottom-up pricing, I'll give you 40% off. Well, that's pretty cool. If you sign just with us only, if you shop only here, right? Best Buy says, I'll give you 40% off TVs if you buy your TVs here. Oh, how much for TVs? I'm sorry, we can't share that. That's a problem. Because I'll give you 99% off of my truck then. I'll charge you $1 million for it, right? So, what we need is the price, and we can look at claims, but should we have to? I get it, right? But this narrow network of, if you agreed for this 40% off and you agree to shop here, you actually are signing away your ability to shop around for a better price or a better quality. You're willingly signing away, so be careful of that. So we convert over to the right and we say, okay, this interruption, right? We have a plan design that makes it good for the members to choose wisely. We have the clinic we have available, not mandatory, but we have an independent DPC, direct primary care clinic, that is our funnel. They can go there for no cost, not for the company, but for the member, right? But you go there for no cost in many cases. You can structure it how you want it. But then we guide care, we give 30 minutes, 45 minutes, you can get in the same or next day, 60 minutes. And you get good quality primary care, and then we can refer smartly only when needed. We can get a surgery that might have been 70 grand, we can get it for like 20. Real numbers. We can get an MRI that would have been 5 grand, we can get it for 60. That's where we can start. And when you save money on the plan, guess what? You can lower your deductibles, lower your premiums, get your plan where it should be. So we're kind of creating a new system, right? We still have the dirt road. Some people get stuck on this and they say, Matt, you'll always need the system. careful when you say always, right? But yeah, I get it. ICU, emergency, babies maybe. But we're gonna, whatever we can interrupt, okay, fine, we'll send to the system. We'll have the best contract we can with the system. Maybe we only interrupt 10%. Okay, good place to start. What can we interrupt next? Imaging, ortho, mammograms, colonoscopies. What can we interrupt? Every time we interrupt more, when we send it to a transparent, low-cost provider that's typically higher quality, we save money. So it's not all or none. It's just interrupt what we can. Over time, I know a guy in Oklahoma that's interrupted like 99% of the care. Over a long, like 10 years. Right? So, I want to make sure there's a little time for comments. Yeah, looks like we're hitting the time here. So these are some steps, and then this, I won't get into that, but just kind of strategy type stuff. Even just going self-funded can save you 2 to 3% on taxes, just like that. But it's not, so I would say, like I've been using this race car analogy, right? You can have a mediocre race car that's fully funded. You can switch that race car to self-funded and put a new paint job on it, a new logo, new number, but that car is still a mediocre race car. So some will say, well, we went self-funded, didn't work out so well. Okay, when you go self-funded, that just gives you the opportunity to save. If you actually save or do well, then that's your money. And you're still protected by a reinsurance or stop loss. So it's not just going self-funded, then you have to build that puzzle, right? So just the last slide here. I'm writing a book, we're about 75% done, so hope to have that out by the end of the year. Employer's Guide to Fixing Healthcare. So hopefully that'll be cool. Trying to make it a comprehensive kind of step-by-step, how do I do this, what should I know, book, and then kind of just this comparison of what we're doing at Self-Fund Health, right? Assembling that puzzle, high-performing partners, strategy that many don't know about or don't have, and making that easy button kind of thing, like a fully funded Bupa plan, but a high-performing self-funded plan. So, we've got a little bit of time left, so questions or comments? Yeah. Go ahead, Mike.
Okay. Yeah, the system in Wausau is, I shouldn't identify the people, but they started an insurance company, and the people at the top, this is supposed to be a not-for-profit thing. There are people that are getting way more than they should in that system and stuff like that. And I know there's some people that try to do something about this, but I haven't seen it fixed.
That's one of the, so Mike has talked about the systems, it's people at the top getting big bonuses and so forth, and making big decisions that harm the community. So I think a lot of times it's this paradigm, why do I go here? This is not my favorite talk, as I said, but hopefully it was educational in that we look at these nonprofit. Nonprofit is just a tax status. What we often do though is we associate that with benevolent, selfless, community-minded behavior. And it's often, there's a big disconnect today. If we look at their actions, are they really selfless, benevolent, community-minded, their actions when they're suing hundreds of people every year and putting families in debt and so forth and overcharging it in the beginning? I don't think so. So that's a hard sunlight truth, if you will. And that's one of the recognitions as we say what we, they're providing healthcare. Of course, that's a good thing, right? Well, you got to look at the whole picture, and then we start to make other decisions to say, I got to do something here. This is going wrong. Yeah. What else?
Matt.
Yeah.
Who owns the data? Who owns the company's data? And if the company wants to get that, because you had that's always been a major issue for us is having that transparency on the data. How can companies get it?
I don't know if I can give a technical legal answer on that. I can tell you that I'm sure there are people in the room that can. There's a ton of knowledge in this room, right? But on the fully funded side, the insurance, there are ways, but they're more like techniques. In my experience, most of the time, almost all the time, they will not give you that data. They would say they own it, or there's some sort of clause that they can't share it. On the self-fund side, again, I won't try to give a legal or technical answer. Typically, you can get that data on the self-fund side from your TPA. There's HIPAA rules and so forth. we're actually doing something that will actually offer real-time data, where typically you make a request, you get it a couple months later, it's already 6 months old. So we're looking into a real-time analytical intervention tool through API formats and stuff that no one else is doing anything. But yeah, the data, if you're self-funded, that gives you a big advantage because you have to still respect HIPAA, obviously, but then you can start to look at trends. One of the strategies that I did in the past is it's good to look at your claims data. You should analyze it and see what's going on because you can intervene. But if you want to probably have the best predictability, is just right. At one point, I called the Alliance and I said, "What are the top 5? You got over 100,000 members. I bet that data is my best predictor of intervention." And so we said 1, 2, 3, 4, 5. So we said, let's start there. Imaging was up there. Ortho was up there. ER is like hard to interrupt that. But so there's different ways you can look at where you are, and then also just by pure stats of trends. And the goal would be to interrupt the highest cost. Sometimes you can, like cardiology is up there, but you may only have one every 3 years, but it's a $300,000 surgery. When I was down at the Surgery Center of Oklahoma many years ago, when I first met Keith Smith, I said, "We had a $300,000 heart surgery last week that was non-emergent." He said, "I could have done that for 40. Now that depends if the person wanted to go and stuff. But usually if you make your plan design right, I had Nia tell me before they kind of were absorbed, but I was saying, "Hey, we can get good surgery prices, $23,000 for a knee or hip replacement instead of 50, 60, 70, and all they have to do is drive to Green Bay." So like 1 hour more, you say 30 minutes to the local, hour and a half to Green Bay, and they said they won't go to Green Bay. And they did, and they do, right? So if you could save $5,000 on a car and you had to drive an hour and a half instead of a half hour, would you do it? Like, yeah, be there this afternoon, right? Not only did they go to Green Bay, we did that later actually, but we had 3 hip replacements in the first couple of months go to Oklahoma. Just to get free surgery. I forget, we incentivized it a little bit because Oklahoma's that much lower yet, below 20. But imagine a hip replacement, we put them in first class, but you got a wheelchair through the airport. Imagine the inconvenience, but guess what? They did it. So they'll do it if you structure it right, and they do it voluntarily. We didn't force anything. All right. So we have time for maybe 1 or 2 more. Yeah.
I'm curious, when you talked about the hope and pray method versus the strategy, what can you give an example of what a difference is between just the hope and pray that the vendors work out or that the contracts look good for the business versus an actual strategy that you put in place? Like, can you maybe differentiate between those two things and expound on it a little bit more?
Maybe by hope and pray. Sometimes, right, we think this problem's bad enough, somebody will fix this. Somebody will fix this. Right? So somebody told me years ago, like, Matt, never quit expecting everyone else to fix your problem. So that's part of this, like this movement thing is like, get educated, right? And jump in there and learn about this stuff because you are the solution. Everyone in this room to do things. There is so much knowledge and experience in this room, and if we can all get on the good side, this is a grassroots. We're against a lot of money, a lot of power, a lot of lobbying, all sorts of things. The odds are not necessarily in our favor per se. This is a bit of a charge. Now, opposed to Ben's comment about strategy, right? So I always say start with outcomes. What are you most frustrated about? Well, our premium's too high. We're getting big increases every year. The primary care quality is low, whatever it may be. Okay, well then we form a strategy around that. How do we fix those bad outcomes? How do we get premiums lower? How do we get higher quality care? Keep it simple, and then learn about best practices. There are definitely things out there, so if you don't have a strategy, then you need one, right? But first you have to kind of get a baseline measure of where you are. That's a trend analysis. Are we getting better? Are we getting worse? We gotta know that. And that actually makes it fun, by the way. Maybe I'm just unique, but I love looking at the graphs. How can we get this better? How can we get this better? And bringing everyone along with you, and when they start to see the savings or experience savings themselves, and typically higher quality care, then they come right with you. Does that kind of answer what you're? All right, one more. We can shift. Anything else? So, all right. So if I haven't met you, I hope to meet you today. And just I want to again thank you for coming. Hopefully you have a great day. Hopefully this was a good kind of maybe let go conversation, although not my favorite. But thank you again for being here and for what you're doing. And if we do this together, I really think we can do some cool things in Wisconsin, the fourth state. Thank you.